So let's try and think about some of the other clinical features of sepsis. And while we can't always explain these fully, we can start to have a few ideas that help us along. So we know that in sepsis there's anorexia, but there's increased energy demand at the same time. And this means there's catabolic processes. Now, one of the hormones that stimulates catabolic processes breaking down is glucagon. So glucagon is produced by the alpha cells in the pancreatic islets, and it will break down glycogen to glucose. And it will also stimulate the process of gluconeogenesis, producing glucose from non-carbohydrate based molecules like fats and proteins. And as well as that, in sepsis there's going to be stress. And one of the stress hormones is adrenaline, which of course is exactly the same thing as epinephrine. And I think you can probably see that both of these things, the gluconeogenesis is producing glucose, and adrenaline, epinephrine, also raises blood glucose levels. So we're going to get an increase in blood glucose. An increase in blood glucose levels. And we say if the blood glucose is greater than 6.6 millimoles per litre, in a fasted patient or an anorexic patient who is not diabetic, that is a sepsis criteria in its own right. Now, in a sense, the glucose is good because it's providing energy, but recent studies show that glucose actually needs to be controlled to optimise outcomes in sepsis. So in the clinical environment, we don't want the glucose to go too high. Now, also there's an increased energy demand. I think you can see that oxygen is going to be used and carbon dioxide is going to be produced. So if the oxygen is used up, the amount of oxygen in the blood will go down. And as energy is produced, the levels of carbon dioxide will go up. So increased use of energy is going to decrease the amount of oxygen left and increase the amount of carbon dioxide produced. And that's going to be detected by the medulla oblongata, where there is the respiratory centre. And that will stimulate respiratory rate. Also, the decreased oxygen and the increased carbon dioxide will increase heart rate. That will also be increased. And if you increase heart rate, that's going to increase cardiac output. And blood pressure is cardiac output multiplied by peripheral resistance. So we're going to get an increase in blood pressure. And as well as that, if someone has got chills and rigors, they're going to be peripherally vasoconstricted. The peripheral vasoconstriction is going to reduce the amount of blood going to the surface of the body, retaining warm blood at the core of the body, but it can also increase peripheral resistance. So these are other effects that we can see in sepsis. We can see raised glucose levels, we can see increased respiratory rates, increased heart rates, and increased blood pressure. And actually very often when someone is becoming ill, it's the respiratory rate that can often increase first. So this is a key clinical indicator, keeping an eye on the patient's respiratory rates. But all of these things can indicate the onset of sepsis, and we can use these to monitor the course of sepsis as well. For example, the degree of hyperglycemia is actually well correlated with the severity of the sepsis. So there's like a positive correlation here, if we think of the graph. So if the blood glucose levels are there, and severity is here, severity of the sepsis, the blood glucose levels will tend to rise as the sepsis becomes more severe with this positive correlation. So for us as clinical workers, lots of things to keep an eye on: to monitor the presence of sepsis, to identify the presence of sepsis early, and to monitor the course and severity of the sepsis as well.